Okay, welcome back everybody. I hope you are all refreshed after a nice lunch and excellent poster session. We are going to start again this afternoon with the cardiovascular session. It's a pleasure for me to introduce Professor Mattias Stuber. He's a full professor at the University Hospital of Lausanne and the director of the Center for Biomedical Imaging. Mattias began his career working at Beth Israel Deaconess Medical Center and Harvard Medical School in Boston before moving to Johns Hopkins and then returning back to his native Switzerland to Lausanne. He's a world leader in cardiovascular imaging and has authored more than 170 peer-reviewed original articles on cardiovascular and molecular MRI. He's received many awards for his research, including the ISMRM's Fellow Award. He also serves the scientific community as a board member of the ISMRM, executive board member of the SCMR, and also a past president of the Magnetic Resonance Angiography Working Group. So today he's going to share his insights on recent advances in cardiovascular MRI. Thank you.
Well, thank you very much for this kind introduction, and also to Sai for inviting me here to this exciting and stimulating meeting. Now I realize I'm the only one in the room who is actually not supposed to fall asleep. Disclosures, do you give any CME credits,
No.
Sai, for this thing? Okay,
We actually hate CME.
All right, that makes us already two. But still, I need to disclose this. I love MRI. So by definition, my opinion might be a little bit biased. All right. Probably I'm preaching to the choir here, but you all know that cardiovascular disease is the leading cause of death in the Western world. Well, of course, MRI has a lot to offer as a non-invasive technique, which you can repeat to guide and monitor therapy, for instance, not only to do diagnostic imaging. And when you look at a routine clinical exam, for instance, at our institution, what's being done, you do some localizers, then you do some cine imaging for function. This is then followed by an injection of a contrast agent. Then people look at perfusion, and then they wait a little bit until they finally can do 2D late gadolinium enhancement imaging to look at the infarcts. Now, here you can see some of these images, how they look like. These are basically the mainstay in many, many cardiovascular centers worldwide. And what you probably notice is that the coronary arteries, which are so important, are missing. Why are we not imaging the coronary arteries? Well, if you look at the state of the art, this was published in 2011 or 12 by a group in Germany. They compared actually head-to-head CT and MR for the identification of significant proximal coronary artery disease. And you can see the sensitivity and the specificity of MR is approaching that of CT. However, there are a couple of caveats, one of which, if you look at the scanning time, where is it here? 17 minutes on average for MR versus one glorious breath hold in CT. And this is not even the most advanced CT technology that was being used. And the spatial resolution, much, much worse on MR as compared to CT, which is, I think, not listed here. But nevertheless, I would like to open a parenthesis, some famous quotes. And one is, I still believe MR is going to make it in the coronary arteries, and that has actually been said by Valentin Fuster at this year's SCMR. And Rod Pettigrew, who just gave a stellar talk this morning, mentioned at some point, motion released the resolution. And I think this is spot on, because if we are looking at the problems we have with high-resolution imaging of the heart, then it's first and foremost motion. That's really the hurdle we need to overcome. Then secondly, it's fairly complicated, and we, tinkerers and engineers and physicists like making it more rather than less complicated. Then often the scan time is lengthy or unpredictable, and the sensitivity of the technique, of course, when to compare to CT, is much reduced. So what's wrong with it? First of all, it's relatively inefficient. If you look at one of these imaging techniques that we're using in this head-to-head comparison, it's very clear why it takes a long time. First of all, you only acquire data in a small window in a period in the cardiac cycle where the heart doesn't move. Then secondly, you have to suppress respiratory motion, and what's being done as a state-of-the-art is the use of a navigator, which basically tracks the motion of the diaphragm. Then you put a window around end expiration, and if data points fall into that window, they are accepted for reconstruction, otherwise they are rejected and have to be remeasured again. And this, of course, this imaging in a short window and then gating to respiration makes the technique relatively inefficient. And just to humor you, me as an engineer, I went into the scanner and looked at how long is actually the AD converter clocking in data. For a scan, that lasts about 10 minutes. So what do you think? All right. During 11 seconds. So during a 10-minute scan, we are only acquiring useful data during basically 10 seconds. This is crazy. I mean, we ought to do better than that. So how could we do that? Then the second problem is the relative uncertainty, and this uncertainty is related to the scan time. If we are using a navigator as here, you can see here an acceptance rate around 40%. That can go as low as 20%, can go as high as 80%, but it basically makes the scan time highly, highly unpredictable. So it makes it really difficult to be integrated into a clinical exam. So if you look at here, and as a matter of fact, the best time to plug it into a clinical exam would be right here, when you have to wait for the gadolinium to wash out of the healthy myocardium. So here you would have a nice time period where you could plug in this high-resolution 3D imaging. Then the second problem is also the ease of use. And if you look at the user-dependent inputs that you have, first of all, you have to get the EKG electrodes right to trigger to the EKG. Secondly, you have to get that trigger delay correct in order to acquire data during a period of minimal myocardial motion. Then the acquisition window shouldn't be too long, but also not too short because of scan time reasons. Then you have to place the imaged volume, perhaps even targeted, which makes it complicated. And then the navigator has to be placed. And finally, the window where you accept the data for during free breathing is also something the user has to do. So you see there is a lot of user interactions that are needed that make it vulnerable to variability. So what's the solution to that? How could we avoid many, many of these disadvantages? And one of the solutions I think we proposed a couple of years ago in 2005 in collaboration with Christian Stening is we take a regular sequence and we do it in 3D. We use a 3D radial acquisition. So here you see an acquisition window. Here you can see the profiles that are actually acquired during that acquisition window. Now what's important is in those data, we can look at the first profile, which goes in superior-inferior direction. We can make a Fourier transform of that profile, and what you get is basically a projection of the entire body onto that profile. So you see here dark in the lungs, you see where it's getting brighter, where the heart is, and darker again, where the liver is. So of course, you can repeat that multiple times, and you can see here the second profile is already shifted. So you can intrinsically measure motion in the data you acquire for imaging without any navigator placement. So you do that a couple of times until your entire case space is full. Then you can run some algorithms. These algorithms then extract the respiratory motion. And this respiratory displacement can then be plugged in to a phase correction of the data retrospectively so that you can correct the position or the phase of these profiles according to the displacement you have measured. And with that, you can correct the heart for respiratory motion, and this is the outcome you see here, a multiplanar reformat of a 3D acquisition. So that's how self-navigation basically works, and this is relatively important for the rest of the talk. Now, luckily, Davide Piccini from Siemens joined us a couple of years ago, implemented this technology on the magnet, and here you can see how it looks. You just basically place your field of view here on the very first scout scan, no complicated plan scanning, no navigator is used. And since it's a radial sequence, you have oversampling in all directions, which makes your field of view basically large and not vulnerable to fault over. And the scan time is 100% predictable. The only determinant is actually the heart rate of the patient or the volunteer. And here you can see a data set in 3 different views. Since it's isotropic spatial resolution, you can cut it every which way you want. And you can very nicely see here, for instance, the right coronary artery as a function of the position you are here in that 3D data set. So when we went back to our clinical exam, then we finally said, all right, let's plug it in right here. So during this wait time, after perfusion, we now routinely acquire these high-resolution 3D data. And here you can see an example. You start a little bit low here in the liver, but nevertheless, you will be able to start to follow the right coronary artery here, and then also the left coronary artery, which is actually turns out to be anomalous in that case. And here you can see a reformat. Again, a very simple exam. Now, we installed that sequence in April in 2012, and then nothing happened. Here on the x-axis, you see the time, on the y-axis, the number of patients we collected. And then all of a sudden, when the technicians and the cardiologists noticed that this sequence is on there, they started scanning like crazy. So every single patient that is now coming on the scanner gets one of these exams. And this is all kinds of patients, also a lot of congenitals. We just published this in JCMR, get this 3D exam, and you can see it keeps going, and now we have more than 1,000 cases that have been scanned with this technique. And at least in my professional life, this was really stunning how this translation from the bench to the bedside really worked, and this technique is now routinely being used. So after the first 70 or so patients, we published this paper in Radiology, and now we are busy to analyze the rest of the data. So I can summarize that self-navigated 3D whole heart MRI reduces scanning time and improves efficiency perhaps from 2% to 4%. So this is still only relative. It clearly improves the ease of use because you do not have to do all that planning anymore. And most importantly, it can be integrated relatively easily into a clinical exam without adding any extra time burden, because it can be used during the period where you have to wait for the contrast agent to wash out. However, there is some remaining inefficiency I just mentioned to you. It's only 4%. And there is a small operator dependency, and that is you have to adjust the acquisition window width and its position before you start the scan. But if you look at this here, actually the yellow ones are again when you acquire data, and the rest of the time you're just sitting around doing nothing, drinking coffee, I don't know what. So again, this is relatively inefficient as a regime how to collect data. So the solution to that is a student of mine, Simone Coppo, actually came up with the idea to just keep pulsing all the way, just pulse, acquire data, and worry about everything else after the fact. And sure enough, he was able to implement that with a BSSFP 3D radial sequence with a phyllotaxis, which is borrowed in nature pattern, and collects these data non-stop. Right now, it's still relatively lengthy. It's almost 15 minutes. Lots of readouts. And here you can see the trajectory again. You have this superior-inferior profile, which is used for self-navigation. And what you then do is, here is one shot, second shot, and you keep rotating this thing with the golden angle. And the golden angle is really magic because it just keeps putting data into K-space where there aren't any data yet. So it never fills the same profile twice. So this makes it highly attractive for imaging and for retrospective collection of the data. So with these red profiles here, of course, you can also use them to get to a motion vector which is related to respiratory motion. And then you can regroup all those profiles you acquired here, and as a function of where in the EKG it actually is. Now my computer is acting up. Okay, let's see. Okay, then you can go in retrospectively into those data. You position such a window of, say, a width of 100 milliseconds, and you just use all these profiles which were acquired in that window to select your K-space. And you can really freely do that wherever you want, however you want, because there will always be profiles that are never duplicated. Okay, so you take that case base, you plug in the motion information as I just showed you with self-navigation, and you can reconstruct 3D cardiac phases, so time-resolved 3D images with spatial resolution which is relatively high, 1.15 millimeters cubed. Okay, then of course you can repeat that throughout the cardiac cycle. You can reconstruct many of these images. I'm not sure what happens here. Okay. Then you can, for instance, get one slice reconstructed. You look at the motion of the coronary arteries. You can identify the period of minimal myocardial motion, and then you can go back into the data and choose some other acquisition windows, as shown here, for instance, in systole, where the heart doesn't move that much, or a longer acquisition window in diastole, where you have a relatively lengthy resting period. And again, you do that all after the fact. And here you can see some results. Here you can see a systolic window of 140 milliseconds width, and you can nicely see the proximal segment of the right coronary artery. However, if you look at the distal segment of the right coronary artery, it seems to be better depicted in diastole. And we all know that the different coronary arteries move differently as a function of time. So it's important to have a coronary targeted acquisition window in terms of time to visualize those coronary arteries. And here you can see a multiplanar reformat as a function of time. Okay, if I now show you all these images here as a function of time after the EKG, you see the red ones are acquired during the systolic rest period. The green ones are acquired during diastole. And so what have we learned from this? I think this technique really substantially improves now the efficiency of data collection. The selection of the acquisition window is now fully retrospective. We can choose the position of the acquisition window as well as the width of the acquisition window totally freely. And we can now simultaneously assess anatomy and function. And I don't show you the data for time reasons, but the function matches very well with 2D gold standards methods using MRI. EKG triggering is no longer needed. You don't have to futz around with navigators. And I think this really will provide a paradigm shift in how cardiac images are going to be acquired in the future. However, the temporal resolution I just showed you is still relatively coarse. It's about 100 milliseconds, and that's related to how many profiles you need in case space to get to sufficient SNR. We have streaking artifacts because of undersampling, and also due to motion correction. Now you have to imagine if you have a moving heart as a function of respiration in your body, and then you correct for it, that actually turns the chest wall into a moving structure, okay? So this gives you additional motion artifacts from structures from outside the heart. So this is something that also has to be considered. And finally, the acquisition time with almost 15 minutes is still relatively lengthy. So luckily, we entered a collaboration with Dan Sodikson and Ricardo Otazo here in New York, who had kind of a magic bullet, which they call GRASP, which is basically compressed sensing and parallel imaging applied to golden angle 3D radial sampling. And if you use that, for instance, to improve the temporal resolution, here you can see it went from 100 milliseconds to 43 milliseconds. So you can see much finer details of the coronary arteries because the motion at any instant, at any given instant, is better frozen. And also it removes some of the streaking artifacts, which you can see here on the left-hand side on this image. So you see here the right coronary artery bouncing around. Okay. So now if I show you the same image as before, I would like to draw your attention to the image here that was acquired at 400 milliseconds, because all of a sudden when I'm now using this GRASP technique, you can see that you can also very clearly identify the right coronary artery at this point in time, where the heart was just moving too quickly for an acquisition window of 100 milliseconds. So of course this technique now could also be invested to shorten the scanning time. In this case here, we just tried to shorten the acquisition window. So what have we learned? In free running for the whole heart MRI, the addition of grasp significantly can improve the temporal resolution. It reduces cardiac motion artifacts. It improves coronary artery conspicuity throughout the entire cardiac cycle, and the sampling artifacts can actually drastically be minimized. However, we still have artifacts originating from the motion correction I just had mentioned, and they cannot be fully avoided. And the second thing we have to consider is we are still talking about a one-dimensional correction of the heart, a one-dimensional correction of respiration. And as we all know, this is not really the truth, because the heart really moves three-dimensionally as a function of respiration. And to make matters worse, this is individually dependent. So in each individual, this motion is a little bit different, and we have to account for it. So the solution to that can again be found in New York in the group of Dan Sodikson and Ricardo Tazo, because what you can now do is you can sort these 3D golden angle K-space acquisitions into different respiratory bins. Like I've shown you before, you can sort them in temporal bins on the one hand, but if you have some respiratory signal you can take out, you can also sort them into adjacent respiratory bins. And because of the golden angle, you again have bins which have sufficient data to be reconstructed into entire images. So what you basically can do is you can regard this as an extra motion dimension that is highly compressible due to data redundancy, and therefore it's well suited for compressed sensing type of reconstructions. So what this means is instead of kind of getting rid of motion with a breath hold or something like that, or correcting motion with, such as with self-navigation, we can actually get to these individual motion states during the reconstruction with this XT grasp technique. So motion correction, as it used to be, is no longer needed. Okay, how does that look? Here you can see now images in 3 different views again. And I just picked one time point in the cardiac cycle in mid-diastole. And what you can see is actually the heart bouncing around its different respiratory positions. So what you see here is not the cardiac contraction or relaxation, because it's always at the same time point, but what you see here, what is changing, is just because of the respiration. So the anatomy is changing because of the respiration. So actually you realize how much it actually does change because of breathing. And mind you, these data here were acquired at no extra cost in scanning time, because we just could resolve the different respiratory positions which we acquired anyways. So it's quite an incredible image quality, actually. And what you can do now, you can go into these data sets and extract the most quiescent respiratory phase, as shown here in the next slide. Now what I did here, I just chose end expiration, and you can now see the different slices in 3D going through the heart. Again, 3D isotropic acquisition. So when I then finally reconstructed this image here out of this data set, it just blew my mind. I've been working in this field for so many years, and now I get such an image of a coronary artery without even having to worry about how I suppress motion. And this is really stunning that this can be done just purely with reconstruction, with sorting data into different respiratory states. So what we've learned is we clearly are moving towards a paradigm where large volumetric data are acquired non-triggered in a continuous free-running mode, where cardiac and respiratory motion is resolved retrospectively, and where EKG navigators and other motion suppression approaches may no longer be needed. So with that, I would like to shift gears and go to a related topic, and that is field cardiac MRI. I'm not sure whether many of you have already seen images of a fetal heart, and the reason is simple. You have a very, very small object which moves a lot. It's like a heart rate of 160. And you have this small object in a relatively big object, and that is the mother, and you cannot, of course, acquire any EKG, so you cannot get the electrocardiogram of the fetus. And again, the field of view you have to acquire has to be relatively large, because you have to have all these parts of the mother around the fetal heart, which you also have to image. So here you can see just drawn to scale how small actually the heart of a fetus is relative to the heart of an adult. So this is quite a challenge, but how can we address this? Well, what we've learned from all these 3D images with the golden angle, we can go a step back and acquire this golden angle in a 2D fashion. So we keep collecting profiles in K-space, and it's fascinating if you look at it, how the profile always automatically finds a space where there is nothing else yet, where there is a void. That's just one of the features of this golden angle. So you keep collecting data like that. And then you can do a sliding window reconstruction. You see the window moving here. And then you have a K-space which is relatively sparse, because there is not a lot of data in there. And if you actually look at the image, it looks rather bad. It has a lot of artifacts. You don't have a high signal-to-noise ratio. But it doesn't really matter, because you can then apply compressed sensing and you get to a slightly better image, as you can see here. And this image you can now use to do cross correlations between subsequent frames. And with these cross correlations, because the heart is moving as a function of time, you can extract from the image data this signal here. And of course, this is like an EKG. You can look at this like an EKG. However, the maximum peak here is not at the R wave of the EKG, but it's during peak systole. So anyway, you have a signal that is extracted from the image data that is basically a fingerprint of how the heart moves. And then you can go in here and detect the maximum, which you then can use to retrospectively bin these frames or these K-space profiles together. So at the beginning here of each of these yellow R waves, which are not R waves, you can collect 4 profiles and put them together like in a regular segmented K-space acquisition, and you get one frame which now has more profiles and a higher signal-to-noise ratio, and you can do that over and over again with an as fine temporal resolution as you basically want, the minimum being 1 TR. And then you can reconstruct an image. And in the next slide, I'm showing you an example. This is not a fetal heart. This is an adult heart. But basically, these are the raw data we acquired. The image looks as bad. And then if you go in with compressed sensing and this EKG extraction approach, then out of the same exact data, you can generate an image with this quality here. So this is quite amazing what you can do without even the need of EKG triggering. But going back to fetal imaging, so this was our first try. It's probably not difficult to see that this is a fetus, and probably you all see where the heart is. It's right here. So the right ventricle is a little bit enlarged of this baby, but there was some concern about some pulmonary problems in that fetus, and that's why we had this patient in the scanner. Acquisition time is around 14 seconds, and the temporal resolution is 12.5 milliseconds without any EKG, without any special triggering technique. Now here we've gotten a little bit better with our parameters, and you can see very nicely the contraction here of the left ventricle in that fetus. Again, temporal resolution 12.5 milliseconds. The heart was beating at a rate of roughly 150. And this is truly only enabled because of the use of compressed sensing on the one hand and the radial golden angle acquisition on the other hand. With that, I would like to thank all those who contributed. First and foremost, my team in Lausanne, then Jörg Schwitter in cardiology, our friend and colleague with whom we are doing a lot of translation. It's really exceptional how this works. Then Davide Piccini from Siemens, who helps all these people here with pulse programming and who implemented this first self-navigated sequence where everything is now kind of depending on. Then the NYU collaboration, which I think is really, really very nice, how we manage across the Atlantic and time distance to collaborate. So basically we acquire the data in the evening when we have access to the scanner. We send it to New York, and overnight they reconstruct it, so when we get up, we have the images reconstructed. So this is really very nice how this works. Thank you, Dan, and thank you, Ricardo, for this collaboration. I enjoyed this a lot. And finally, I would also like to thank the funding agencies which generously support our research. And with that, I would like to thank the audience for listening. And if you have questions, please.
Thank you very much for that wonderful talk. And I'd like to present you with this memento of TMII Symposium
Awesome.
2015. Thank you very much.
It's not
Thank you very
chocolate. Mattias, you can't eat. It's not chocolate.
Any questions, Mattias? Oh, maybe I'll start. So they were wonderful images. The adult coronary MRI first. Are they always contrast enhanced? Have you tried it non-contrast enhanced?
Well, actually, now almost every patient we scan is contrast enhanced for the simple reason that it is part of a clinical scan and they get contrast for perfusion and then late enhancement, and we just plug it into that wait period. So yes, there is contrast on board. But I don't think it makes such a big difference because it's a radial SSFP acquisition, so you have an intrinsic and high T2 contrast, especially we also have a T2 prep in front of our acquisition, that you have a nice T2 contrast also without contrast agent. So you don't really need it, but in our case, it's just for practical reasons, it's often on board. Yeah.
I guess that was the first part. The second part, do you think the speed and SNR would be there to extend those techniques to maybe look at vessel wall, even smaller objects?
Yes, as a matter of fact, I didn't show it for time reasons, but now this whole idea of retrospectively going into the data and looking for the best image, we also applied that to the coronary vessel wall. Right now it only works in 2D, but what you basically do, you acquire the data in a lengthy acquisition window of 400 milliseconds. Then you go in retrospectively and start fiddling with your acquisition window width and your position until you find the best coronary vessel wall image. And so this has improved the robustness and the success rate of coronary vessel wall imaging, as you know, which is not always that great, has improved it considerably. But it's only 2D, and going to 3D is, of course, a challenge because you always need the blood to flow in or flow out. So as soon as you go to a larger volume 3D, you may not have that blood exchange anymore, which is so important to get black blood images.
Mattias, fantastic. Really a great treat. It's so great also to have Dan, double treat we have here. Maybe I ask a question for both of you, related to the last part of the reconstruction aspect. You mentioned that you ship the data, you reconstruct it. I don't know how long the reconstruction, but in a sense, there are a couple of clinicians, do cardiovascular imaging here in the audience. When will this become a real clinical reality? I mean, I understand, it's a generic kind of question, but it's obviously so exciting, and it's going to push the field of cardiovascular imaging to really, to reality, or to make it so much easier. But how far are we from that?
Well, I think for me, the reconstruction time is never a concern because, tomorrow morning when I wake up and buy a computer, it's already much faster than the one I would have bought tonight. So this is kind of a development which is going on for free. And the second thing, we are, all of those among you who are parents, or most of those, are buying Xboxes or some funny stations for their kids to play on. And this is really a tremendous driver of hardware development, which should not be underestimated. And the vendors now start putting these GPUs, these processing units, into their scanners, and so they will ensure that we will have the computing power that is needed to get much faster with those reconstructions. Right now on our computer it takes a night to reconstruct. I guess on Dan's computer, on Ricardo's computer, it takes 2 hours, I don't know. So these are the timelines we are looking at currently, but I'm absolutely certain that in the future hardware will get so much faster, memory will become cheaper, that this is no longer a question whether we have the reconstruction immediately or not.
Yeah, and maybe just to key off of those comments as well, I do think we're heading in the right direction. I think there are also some new directions that might be very valuable for clinical implementation. Susumu referred to them a little bit in his talk. The notion of cloud computing starts getting very interesting in this kind of model, because at the moment our model of reconstruction is that we have a scanner, and we have sitting next to it a little reconstruction engine. And even if it has a couple GPUs on it, if you think about the way it's used, almost like you were saying, we use a teeny bit of the actual acquisition time when the ADC is on. Likewise, we have this huge reconstruction load that comes into the scanner when a scan like this happens. And then we're waiting while we acquire. But part of the paradigm that Mattias was showing was that actually, in many cases, you're going to want to retroactively mine the data again. So you're going to want to be sending recon jobs at odd times, sometimes maybe even during the interpretation, if you can get fast enough. So the notion of a cloud that you can send to and you don't have to worry about sort of your workflow in the same way is very interesting. And then maybe the last comment I'll make is in terms of clinical adoption, because that seems to be one key theme of this meeting too. That slide that you showed, Mattias, of the adoption of your free-running coronaries, which was dramatic, up to 1,000 patients as soon as people realized. We've actually seen similar effects, say, for grasp in the abdomen. It took a little while, but once clinicians saw it and once they realized, wait a second, I don't have to do a breath hold here. I can actually capture pediatric cases where they're moving. The adoption rises up into the thousands remarkably quickly. So I think, in some ways, if we can address these key issues of workflow and convenience and complication, I think we have a much better chance of adoption than with kind of classic, complex, difficult workflow techniques.
Any more questions?
Yeah, thanks. That was a spectacular talk. I really enjoyed it. So just two quick questions. What was the magnetic strength, the field strength that you were using for those images, and if you have tried it in patients with arrhythmias and whether that creates a problem in the image quality?
The field strength so far, this has all been done on 1.5 Tesla, because it's just easier to run a BSSFP sequence without fiddling too much with shimming, etc. And the second reason why we do it at 1.5 T is it's just the magnet where the patients go. So it's as simple as that. So in our institution, we have 4 different machines from the same vendor, and my students implement all the sequence on every machine just in case a patient comes, that we don't lose any patient data. But the majority of these patients are at 1.5 Tesla. And then the second question was related to arrhythmias. Yes. Now, fundamentally, we already studied this in the case of the 2D acquisition, where I showed you the movies of the heart, where you don't need any EKG triggering anymore. And if you may have noticed that we had a yellow dot when we identified peak systole, and we have a blue dot where we identify peak diastole. So in our algorithms, we always enforce that a yellow dot has to be before a blue dot to accept the data. So if you have an arrhythmia, you do not have necessarily a diastole in there, which you can identify. So these data can just be taken out and do not contribute to the reconstruction. Now, in a general Cartesian scheme, you couldn't do that. You cannot just toss away data and then reconstruct, because you would get a lot of artifacts. However, in such a radial case, you just take out some profiles and you don't really get additional artifacts. You just get a tiny bit more noise. In fetal imaging, this is important because, as many of you know, fetuses tend to move. They don't hold still when you tell them to. So you acquire the data in an orientation where you had your scout scan. You acquire the data of the heart, but then the fetus happily decides to move, right? So that means of these 12 or whatever seconds data we acquire, perhaps after 7 seconds, the fetus moved. And again, we just can toss out those data because it's a radial acquisition. It doesn't really matter. It just adds a little bit of noise. And I think that's also why the first fetus was noisier than the second one, because that one moved. So you can take the data away, and you solve these kind of time inconsistencies which hurt us a lot in MR. And then translating that to the 3D case, I'm convinced that we will get rid of the EKG. We will no longer need that. It's all in the data. We just have to be smart about it, and then we can also toss away arrhythmias very, very easily. And by the way, I mentioned Ricardo and Dan, but I also should mention Li Feng, who is doing really a lot of the legwork and implemented those algorithms and reconstructs. When we are asleep, he is doing the reconstruction. So thank you to you too.
Okay, any more questions? I think so. Thank you very much again. Thank you.